afternoon, everyone. Welcome back to my IVF Answers and the European Fertility Society. We are back with more webinars. We are back with today's topic, which is definitely an intriguing topic, still new topic, and I'm sure it's going to be an interesting topic to discuss. As you know, we will discuss PRP, uterine, but also ovarian rejuvenation method, and we have our special guest with us already, Dr. Estefanía Rodríguez is with us. Hello, Estefania. Thank you so much
Hello.
for joining us tonight. I hope you are having a good day so far and are ready to explain what PRP is and are ready to introduce us a little bit more and give us some more details on this particular technique. How are you today?
I'm good. And I have been working until now, and I love this topic, and I'm gonna try to explain a little bit about that and indications and how do we work with that.
Brilliant. We are definitely looking forward to it. Let me just mention that Dr. Estefanía Rodríguez, she's the medical co-director and head of research unit and gynecologist at IVF-Life group in San Sebastian. You're located in San Sebastian. So I'm happy that you are here with us. And of course, as always, we will start with Dr. Rodríguez's presentation, our topic. And afterwards, there'll be time for your questions. Remember, you can put those questions in the chat during the presentation or afterwards. Remember, this is your time. So whatever you would like to ask, go ahead, type this in so that Dr. Rodríguez can help you out. And before we start, as always, I encourage anyone who would like to help us out. There are options to volunteer. We are still looking for some perhaps patients that would like to help us with transcriptions. If this is something you think you might be able to help us with, get in touch with me. I will put my email address in the chat in a second, and you can get in touch with me. I'll be happy to give you some more details. And right now, I think we cannot wait to hear what you have prepared, Dr. Rodríguez. So let's get going with our presentation already, okay?
Thank you.
Brilliant.
Yes.
Thank you so much indeed.
Thank you. So today we are going to talk about uterine and ovarian rejuvenation in relation with plasma rich in growth factors. So a small index in the beginning about the concept of PRP and how does PRP work. Then we are going to talk about the effect on tissues and PRP application and objectives. How is a candidate for PRP therapy, and how do we prepare this kind of treatment. And then I will talk about ovarian PRP, the procedure, and a little bit about the embryo banking strategy that we recommend. And in the end, the endometrial PRP, the procedure, and the treatment. So here we go. About the concept, PRP is an autologous plasma rich in growth factors extracted from the patient peripheral blood platelets. It was first used in 1987 for an open heart surgery. And nowadays, it's widely used in many medical procedures in traumatology, in surgery, ophthalmology, and now we can use this procedure in gynecology. And we are nowadays with this treatment inside the uterus in the endometrium, and we are using it also in the ovaries. So, how does PRP work? First of all, I'm going to talk about the effects. We know that PRP promote angiogenesis, vascularization in the tissues. It stimulates cell migration and increases cell proliferation, and it also reduces inflammation and stimulate autocrine and paracrine secretion of growth factors. And we have many studies about the endometrium PRP, and we know that it can increase proliferation and motility of endometrial fibroblasts and endometrial cells, and this can increase endometrial thickness, because we know that one factor that can be related with a bad result in our treatment with embryos can be endometrial thickness. Okay, if the endometrium doesn't arrive to a good size, the result, they are lower. Okay, so it can increase the expression of growth factors by endometrial cells, and it can increase the expression of other components in endometrium, and this can improve the function of the endometrium and increase the implantation rate, that finally this is the objective, to get pregnancy. We can use PRP in the endometrium and in the ovary. The indications and objectives, they are quite different if we use this treatment in these places. We have talked about endometrial objectives, endometrial functions, and in the ovary, PRP can also improve angiogenesis, but vascularization can increase the functionality of the ovaries, the follicles, finally, where we are going to get the eggs. It can stimulate cell migration and also autocrine and paracrine secretion of growth factors. We can increase with PRP follicular activation, and then we can have improve in ovarian reserve markers. And with this, what we want is to increase the stimulation of follicles inside the ovary. We want to activate the follicles, and if we perform a stimulation program, in its case, we can get, what we want to get are more eggs, and finally improve the result in our treatment. Where can we use the endometrial PRP, or where do we indicate to use the endometrial PRP? When we have adhesions, because we can't reach a good endometrial thickness. If we have an atrophic endometrium and we don't know why, and we can't treat with another treatment this problem, we think that a thin endometrium is less than 6.5 millimeters. And with this, we want to increase the implantation rate. When we have chronic endometritis, these patients, they have a bacteria maybe, or a microorganism inside the uterus in the endometrium, and we can treat the inflammation and the problems that we have inside the uterus with PRP. And nowadays, we are also indicating the PRP when we have implantation failure, maybe more than 2-3 embryos on day 5 transferred, and repeated miscarriage. And we don't know why, we don't have another issue, and we can introduce this treatment to improve the result. When can we introduce the ovarian PRP in our treatment? With low ovarian reserve patients, with premature ovarian failure. These both are in relation with a low quantity of eggs and low quantity of follicles inside the ovaries, and perimenopausal patients and menopausal patients where we have problems with cycles. we can also try to improve the function of the ovaries, improve the hormones that the ovary produce, not only the eggs, okay? Because if we restart the function of the follicles, we can improve the hormones, and we can improve the quality of life of our patients. So there are many indications about this kind of treatment, and we are studying the results in these cases. So I will start explaining a little bit, because there are some contraindications with PRP treatment. We have to select the patients where we are going to introduce this kind of treatment, and we have permanent contraindication and temporary contraindication. For the permanent contraindication, we have the severe heart diseases, and we have the history of hepatitis B, for example, or hepatitis C, and other infection, active infection. And for the temporary contraindications, where we can maybe in the future after treatment perform this kind of treatment, can be bacterial infection, or people with blood or coagulation or autoimmune disorders. And then we evaluate if there is a severe uterine factor, like malformation or uterus deformed by fibroids, for example, and cases of oncological history or active tumor. We have to evaluate each case. And also the patients with autoimmune or degenerative disease, we have to evaluate each case to treat with PRP. How do we implant the protocol? What we usually do is to stimulate more than one time the patient to introduce the PRP inside the ovaries when we are going to collect the eggs, okay? So we usually start with with a menstruation, the stimulation program for fecundation. And then the same day that we are going to extract the eggs, we extract the liquid that we have inside the follicles, and then we introduce a PRP inside the ovary, okay? We have to prepare a PRP. In our clinic, we do all the preparation. We prepare with a blood sample. We take a blood sample from the patient, and we have to centrifugate that sample to introduce, to take the part of the blood that comes with the plasma, with the platelets, okay? This is a very safe treatment because the plasma comes from the same blood that from the patient blood, okay? So we don't usually have secondary effects, okay? We collect the eggs the day of punction, and then we introduce this plasma inside the ovary. After the injection inside the ovary, we wait 1 month, and we repeat ovarian markers. What we usually do is to take anti-Mullerian hormone result, and with an ultrasound, we evaluate the follicles. And then we can know if the PRP has produced a change inside the ovary, if it has activated the follicular function, okay? So if we have a good result, we can start with the second stimulation. If we don't have good result, we can wait another month, and then repeat ovarian markers, repeat the ultrasound to check if then we have had a good result. We think that more than 3 months it doesn't work if we wait more than 3 months. It doesn't work more than the first 2 months. Okay, so that's why in this moment what we are waiting is usually maximum 2 months. Okay, and then we repeat the stimulation, and in some cases we can repeat this for 3, maybe 4 times. Okay, so we can cumulate at the end the stimulations and cumulate the eggs and the embryos. What we usually do is to perform the fecundation the day of collection eggs, and then we cumulate the embryos, the embryos on day 5, to have more chances of good genetical and good quality embryos. Here we can see an ultrasound with the ovaries on the left side, and on the right side we can see how do we collect the eggs with a vaginal ultrasound, and then we take the liquid that we have seen with the ultrasound, and we can extract the eggs and introduce the PRP there in the ovaries. For us, it's easier to introduce the PRP when the ovaries they are stimulate a little bit, but this can be also done without an stimulation program. That's what we usually do, what we recommend to do. Okay, but with a menopausal woman, we can introduce the liquid inside the ovary, and we usually don't stimulate the ovaries, okay, because they are not activation of follicles. Okay, if that's the protocol, if we have to check the endometrial, the ovarian markers. If we have a positive result and we have positive changes in the ultrasound, and the anti-Mullerian hormone increase, or maybe we can check FSH and that it decrease. Okay, those are markers of good ovarian response. Okay, we can start ovarian stimulation. If we don't have good result, we wait 2 months to check. Those are the objectives that we can have when we introduce PRP in the ovary: improve ovarian reserve and egg quantity, and if we select menopause or perimenopause woman, we can restore menstrual cycle and maybe natural conception in some cases. And this have a potential to improve the embryologic and reproductive outcomes. If we can have more eggs at the end of the stimulation program, maybe we can have a better result. We can have better result. What the protocol in endometrial PRP is different. We have to, here in these cases, we already have the embryos, so we are going to transfer. And what we want to do is to improve endometrial function, okay? What we can do is, what we usually do with the protocol is to prepare the uterus the same as we are going to transfer, and we prepare the PRP with the blood sample, and we keep PRP in our clinic, okay? And then when the uterus is prepared, we can introduce the PRP inside the uterus, or we can introduce directly, or we can introduce with a hysteroscopy. We can see with a video cam and introduce behind the endometrium. That depends on the case. In some cases of important uterine adhesions, we can introduce behind the endometrium and try to improve the result, okay? But what we usually do is to introduce directly inside the uterus. Okay, then this is usually done 3 times. There are different studies about the protocols. That's the most important problem that we have with the evaluation of results, that in each study and in its protocol is different, and we have different ways of introduction of PRP. We have different protocols about the quantity or about the procedure. So what we need now is to continue with these studies. We have to continue collecting information about the studies, and I think that in the future we will have more information about the result, and that this will help our patients. And we have to select very well our patients to introduce all this treatment. Okay, and nowadays we recommend to introduce the PRP 3 times. But that depends on the case, okay? Because we have to check if the result is good with the ultrasound, if the thickness is improving or not. Maybe we can introduce 4 times, and that depends on each case. This is not close. And what we usually do with ovarian stimulation is recommend, as we are going to stimulate 2, maybe 3 times, we recommend the embryo banking strategy. With this kind of strategy in women with low ovarian reserve, we can stimulate 2, maybe 3, 4 times in 2, 3, 4 months, and try to the objective is try to keep between 4, 8 eggs, embryos, and with this with the kind of strategy we can study the genetic, and then we can improve the result. We can give more probability of good genetical embryos. We have to know that the embryo quality, that depends on the age of the woman, and if we have a chromosomically normal embryo, we have a very high implantation rate. This is around 80%, and we have to get this embryo. Okay, so if we can stimulate a little bit more the ovaries, we can have more eggs. Maybe we can get more good embryos to transfer and to increase this implantation rate. This is finally the objective. So this is our team here in IVF San Sebastian, IVF Donostia. Thank you for listening this webinar, and we have more clinics here in Spain. And if you want to contact, we can do a consultation with your case, and you have here all the contacts.
Brilliant. Dr. Rodriguez, thank you so much for your introduction and explaining what PRP is, not only ovarian rejuvenation, which is, I think, most patients ask for that, but of course about uterine rejuvenation as well. And as you can see, we already have some questions. So if you have more questions, go ahead, type this in. This is your time. Dr. Rodriguez is right here for you to help you out. And of course, I think we can start with some of those. The first question is from Marie. Does it work with women in peri or menopause?
There are some studies about the introduction of this kind of treatment inside the ovary with menopause or maybe perimenopause. And there are some cases, because what we think that the PRP is doing there is to activate the eggs that they are we're going to say asleep. Okay, so asleep. So we can we can improve the function of the ovaries. That's finally the objective.
All right, thanks so much for this. For your first question, more questions are coming up, and the next question is: when is the best time to do endometrial PRP for IVF, and when is the best time to do it for IUI?
For we have to think that we have to wait a little bit just before the transfer, okay, just before the embryo implanted inside the endometrium, okay. So we have to try to do it maybe maximum 2 days before the endometrial the transfer, okay, the embryo transfer. So what we usually do is to start with the installations, to try to do 3 installations. That depends on the cycle, and in some cases it's a little bit difficult, but we try. So if it's the preparation is done in natural cycle, it's more difficult, but we try to do 3, and the last one just 2 or 3 days before the transfer, okay, to try to improve the endometrial function just before, okay. I don't have experience with the PRP in intrauterine insemination, okay? But I think that we have to bear in mind the same things that with with the embryo transfer, okay? So if we do this procedure, we will do it just before the embryo implantation. So just days around the insemination, because the insemination we are going to do just in the day of ovulation. So then after it's gonna be naturally the fecundation, and then the embryo has to return to the uterus. So we will have to do it, I think, just before. But I don't have experience with this kind of treatment.
All right, that makes sense. There are 2 follow-ups from Marie, from our previous patient. Okay, so let me just show you. So did I understand correctly? Do women in menopause still have eggs in a dormant form?
Yes.
Okay. Next one, meaning
Can
they could
be.
get pregnant. They could get pregnant with own eggs.
Meaning they could impregnate with their own eggs. It's not impossible. It's not impossible. In medicine, there is nothing impossible, but the quality of eggs is the point. So nowadays we can't change the quality of eggs. That's for me, that's a problem here. But yes, in number maybe we can have, but then when we want to produce embryos, the quality and the genetic is not gonna be good. If that depends on the age of the woman, okay, like, because we are talking maybe about a woman with more than 40-45 years. But if the age is young, if the woman is young, maybe we can get a good quality egg.
Okay, there are some things that we need to clarify, yes, because there are some questions regarding does premenopausal start around 45?
Premenopausal start when we have problems with the cycles, when we don't have many eggs and our body can prepare for ovulation. That depends on the woman. There is the when we usually talk about menopause, we talk about 50 years, but some women can arrive there with 60 years, and some other women with 25. So that depends on the cycles, not the age.
Yeah. So this is it's impossible to say. Every woman is different. It can be.
Every woman is different in this case.
Okay, because as you can see, there are some so we need to clarify: is it still possible to be pregnant with your own eggs? Yes, it's regarding premenopausal aspect, I think.
Yes. If we have eggs, we have the opportunity to get pregnant, and there are some cases, women that they think that they are menopause, and they are pregnant because of the age, maybe. But we have patients, young patients, with less than 30 years that they have menopause because of some problems or maybe genetic, and we have to think about all these cases. Yes.
Of course. All right. Hope that helps. One more to just clarify: is there a set deadline when you can do PRP post menopause? Would the eggs be okay?
Is there a set when you can do postmenopause? It's be okay. That depends on the age. With more than 43 years, it's quite difficult to get good genetical eggs. That's a little bit the point. 43, 44. And if we don't have many eggs, it's like lottery, because we have to get a good quality egg, and that's quite difficult. And if we are menopause and we can get one egg, this is quite difficult. Yes.
Okay. Thank you, Laura, for your questions, your follow-ups. And let's go to the previous question. There are two from the same patient. My uterine lining is 6 millimeters. To improve the lining, I'm thinking of doing PRP, uterine rejuvenation. What are the risks? Is it okay to do it as PRP or treat the thin uterine lining when doing IVF? There is a follow-up. Let me go through that. I've got to mention I'm already going for PRP for ovarian rejuvenation, so I want to do it at the same time.
Yes, that's the best case, because we have less than, say, 6.5 millimeters, and if we don't have other factor, we can treat with PRP. Is a very safe treatment, and we use, what we usually do is to introduce the liquid inside the uterus before the transfer. So you can do both treatment, ovarian at first, ovarian for the stimulation program, and before the transfer, endometrial PRP. That's possible.
All right, so it's possible to do those at the same time. Thank you. And if you can just, you've mentioned how long after PRP ovarian rejuvenation can one go for IVF?
What we usually do is check ovarian markers just 1 month, 2 months after the injection, and we check if we have if that improve. So there are not limits to start the stimulation, but we try is to start in the best moment, so we can wait a little bit. There are some studies that they wait more, but in our experience, we don't usually wait more, because we think that then that can't improve.
Okay, that makes sense again. So it's better not to wait too long. 1-2 months tops seems like the best option. Okay. Do you recommend PRP for improvement of endometrial thickness on specific days of the cycle prior and after embryo transfer?
Just before the transfer, okay? And maximum, what we usually do is maximum 2-3 days before transfer, okay? To try not to touch the endometrium just in the window of implantation moment, okay? So that's the protocol nowadays, and we can check with the ultrasound if the thickness is improving, and we have good result.
Brilliant. Thanks a lot again. And what is the cost of the procedure? Are you able to tell us about the costs a little bit?
But that depends. Nowadays in our clinic we have we don't, as we are we have started in 2022 with this procedure. The cost is not very high, but that depends. You have to ask directly to the clinic.
That makes sense.
That depends on the procedure. The ovarian PRP is different than the endometrial PRP, so that depends.
So remember, if you wish to get some more details on the cost, remember you can get in touch with contact at ivf-spain.com, right? This is the email address you can use, and I'm sure the team will be happy to give you some more details. How do you activate PRP procedure?
What we do is just activate before the injection, and this is done by the technical person that is there in the clinic. That depends if we have keep the treatment, or we are in we we are with the procedure, with the centrifugation in the same moment, and they have to prepare for us, and then we inject the PRP.
All right. Again, thanks a lot for your question and your help with that. Some more questions are here. And next one is from Loretta. I had 4 failed embryo transfer, no implantation at all. I was on full immune protocol. We now suspect problems with endometrium. Hysteroscopy came back clear and lining always above 10 millimeters. Would uterine PRP be an option for me?
Nowadays we are in our indications, we are with this kind of patients with problems with implantation, and when we don't know for sure what's the problem. And yes, nowadays we can introduce this treatment in these cases with these problems. Yes.
Again, hope that helps. I believe so, of course, as well. The next question is, so can this procedure help in case of presumably low quality of embryos because of the past history of endometrial cyst in ovaries? As well, the ovarian reserve is low, and that presented the difficulty to collect many eggs, even when I did it first time at 36. Now I am 42. What would you say in this case?
That we can't improve quality of eggs if the problem comes from the quality of eggs, because I'm not sure, because this is the quality of embryos, so we have to think about the sperm also. But we can't improve the genetic with this kind of treatment. So with more than 38 years, the genetic is important there. We can try to get more eggs, more quantity, and then try to improve the probability of a good embryo, but not the quality.
And this is, you just entered this, but here's the question: can we improve the eggs quality?
I would like to tell that there is a treatment to improve the quality of eggs, but nowadays we have some strategies in some specific cases, okay, but not with PRP. This is not maybe the objective. There are some studies that tell maybe we can get more mature eggs, and with this improve the proportion of fecundation, but not the quality to produce more embryos, maybe, or the quality or the genetical quality. Okay.
Okay, again, thank you so much for the clarification. This is always a topic that comes back, obviously, and unfortunately, at this point, we don't have like a proper, solution for it. That's the truth.
There are some strategies for
Yeah.
some specific problems, maybe polycystic ovaries or something like that. But in general, in relation with age and those things, we don't have nowadays a specific treatment to improve the quality.
Okay, of course, understood. Thank you so much. So would your clinic offer the procedure along with an IVF treatment to improve egg quality for a 45-year-old trying with own eggs?
For to improve egg quality, no, because we have many problems with the genetic with these ages. So we can try to get more eggs, and then try to accumulate embryos, and get a better probability of good embryos, good genetical embryos. That's the problem. That's what we usually see with for 45 or with more than 40 years.
Okay, I believe again that was clear. And just to clarify, is it better to do PRP for uterine lining or wait during IVF?
Better. I think that's different because in some cases, if we wait a little bit more and we increase the days with estrogen, for example, maybe we will get a good lining, a good thickness, okay? And in some cases, we can't. So we can use PRP and then improve the lining.
Okay.
That depends.
Of course, it's not always easy to,
No,
mostly,
we
it's
have
not
to.
possible, yeah, to just
Yes.
say, it's yes or no, or it's black and white, unfortunately. There are some more questions coming up. At this point, I see two questions. One is a follow-up, which I missed. I'm sorry, but Marina, of course, I see it right now here. So I have to add, it's regarding the question. Let me just go back so we can see it possibly. Yeah, this is in the case of low quality embryos, 42. Patient is 42, and the follow-up is here. So I have to add that I have made 3 embryo transfers with the long protocol with blastocyst for 5 days and 1 with day 3 in the short protocol. For morphological quality was assessed as a good one time the biochemical pregnancy took place. Anything else you can advise?
We can use PRP in these cases in endometrium because we can use it when we have pregnancy losses also. Okay, that maybe can we first of all we have to evaluate more things about this case. It's not easy because we have to know that there are no immunological problems, or we have to think about a lot of things. So but yes, we can try to improve the endometrial implantation rate with PRP, and maybe if you have to proceed with another stimulation program and you have low ovarian reserve and not many embryos, maybe you can try ovarian PRP.
Okay, and I'm sorry, there's one more question. Sorry, just give me a second. I think that's... Hello? I hope you can hear me right now.
Hello.
You can hear me. Okay,
Yes.
good. Sorry about this. I was, I don't know, connection was lost, but I'm here. So here's the question from Marie, and this is a follow-up. What about the quality of cytoplasm? I didn't have problem with genetics so far, but with the quality of cytoplasm, this was what doctors believed, no problem with thickness of endometrium.
Nowadays we think that we can't improve the quality of cytoplasm. That's a problem in some cases, maybe for the energy of eggs to produce embryos, maybe with problems with the division of cells. We have now one patient with this problem, that cells can't divide, but we can't improve quality now.
Understood, of course, as well. Okay, next question from Samara. With ovarian insufficiency, what are the chances of getting pregnant with PRP therapy and get own eggs?
That depends on the quantity of eggs, because if we have an insufficiency, maybe we have some, and that depends on the age. Okay, that's important. And if we have maybe one egg and we perform an ovarian stimulation and we get that egg and we fecundate and we have a blastocyst, that depends, because the treatment is not only the stimulation program is not only a treatment, it's also diagnostic, so we can get information about the quality of eggs and finally the quality of embryos. So that depends on each case, that depends on the quality and how many embryos can we get each stimulation, and then a genetic. That's the point.
Okay. Again, I believe that was helpful. So thanks a lot. We will be slowly finishing. There are like few questions left, but of course, if you have more, you know what to do. This is the last call for those questions. So please go ahead and type those in. And the question next that we have is PRP procedure done with or without anesthetic?
The ovarian PRP is done with anesthesia, is that with a small anesthesia, because we are going to introduce the liquid inside the ovaries. If we have only one follicle, maybe we are going to, what we try to do is to introduce the PRP in different points inside the ovaries. So we are going to try to puncture different points, so that can be a little bit painful. With the endometrial PRP, we can, that's like more or less like a transfer. So we don't usually use that with, do that with anesthesia. But ovarian PRP, yes.
Crystal clear again. Thank you so much indeed for this explanation. And this is like off topic, but I think we can definitely answer. So is it possible to have a Zoom call or a call? Yes, arrange a call
Yes,
with
yes.
yourself.
We can do online call, and if you want, you can contact us and we give you an appointment to talk about your case and try to get um, um, to respond your question, to answer
Brilliant.
your question.
Yes, as always, remember to get in touch directly with the team so you can arrange a call, and you can, of course, definitely ask for Dr. Rodriguez, I'm sure. So I hope that helps. And there are more, there are like few questions, two questions more. Is PRP more effective than Neupogen? I'm sorry, not familiar with that. Wash to increase endometrial thickness before transfer?
There are different treatment. Nowadays, we don't have studies that compare the different treatment that we can offer. I expect in the future that we will have those studies. And what we like about PRP is that is quite safe because it comes from the patient, and we don't introduce medical issues, and that's important. Okay, we have to think about the result, but also about the secondary effects. So that's important. But I can answer this question nowadays with the studies.
Of course, that makes sense again, of course. Okay, do you have any statistics for live birth after PRP?
Nowadays in our clinics we don't have this result. We are taking our information about that, but in what we do is to select all the patients. So they are difficult cases where we have other problems, and the statistics, they are quite good in general studies, but here that depends on the clinic, because that depends on how we work with embryos. So we have to check, and we will inform you in the future. I'm sure that we will have with our own patients more information, but we are having good result in difficult cases. So I'm quite happy with this kind of treatment.
Again, thanks a lot for your question. Hope that helps. Possibly our final question from Marie. Can you please remind us the side effects, if any, with the PRP?
Yes, maybe we have a risk. We always, when we touch the uterus, when we I'm going to talk this different for endometrial and ovarian, but with endometrial PRP, we have risk of infection because we are introducing a liquid, and that's why we have to do this treatment with a strategy and with a protocol. Okay, we haven't had a problem like that, but this is a second side effect, an infection inside the uterus maybe. And if we have a reaction, that's why we have to well select the patients. Okay, if there is a immune disease or a problem like that, maybe we can have a reaction, but this is not frequent. And with the ovary, those are the same effects that with the egg collection, egg extraction, because we are going to introduce the liquid inside the ovary, so maybe this can produce a bleeding or maybe an infection, or that's quite, it's not frequent.
Again, brilliant. Thanks a lot for yet another question. We are coming to an end, but I'm just seeing that someone is typing, so let's give it a minute. Let's see if we have a thank you or it's another question. I definitely want to make sure that we were able to answer all of your questions. So let's give it a minute. As you can see, there are some thank yous coming up as well. And yes, we do have another question here. How can we see if we have any dormant eggs when we are in peri or menopause?
We can't see that directly. We can't see that. There are many studies about pathological studies about the ovaries in menopausal woman, and we know that we can have some cells there. So that's why we can introduce this kind of treatment. But this is like the question about the quality of eggs. We can't do a blood test. We can't do an ultrasound to check the quality of eggs, and we can't do a blood test to evaluate this situation.
Of course, again, it's tricky. It's difficult. Thank you for your question. One more interesting question that let's have a look. So I read that someone who had PRP had lower AMH after PRP procedure. So there was no improvement and even lower AMH. Is it possible?
We naturally we are going to have lower ovarian markers with the age, so that can happen. That yes, that can happen, but maybe an immune reaction, maybe. I don't know the case, but that could happen. That's not frequent.
Okay. Yeah. Okay. Thank you so much indeed. And one more, are there any risk when it comes to ovarian rejuvenation?
Yes, the same risk like that we have with the egg extraction, egg collection. Because we are going to introduce the liquid, we are going to collect the eggs, the follicular liquid, and then we are going to introduce the PRP. So,
Okay.
yes.
Yeah. Okay. One more here. Is it recommended to do some immunological tests before PRP? Do you mean that the gynecological immunological problems, or generally, is it possible not to be aware of these health problems?
In many cases, we perform immunological test, blood test to check because this can be a factor that decrease the implantation rate. So yes, we don't usually do that in asymptomatic patients if they don't have disease, but to check if there are some other factors, we can do those tests. Yes.
Okay. Again, thanks a lot. One more from Marie. Ultrasound analysis is stating that there are no more eggs. Is it a definite response when looking for dormant eggs?
what we can see with the ultrasound is there are the follicles. So if we don't have follicles, we don't have activated eggs. That's what that means. So but because what we can see is the liquid inside the follicle, and then the egg is inside the liquid. So we can't definitely tell that we don't have eggs. That's
Okay.
it's
Yeah.
impossible. And we have many patients, maybe after menopause, that one day have menstruation, and then we check, because we have to check after menopause, and we confirm that they have ovulate in
Yeah.
with 60-65 years. That's well, very frequent.
Okay. Okay. Thanks a lot. Again, here, if you can explain. So I had the PRP procedure about 6 years ago, ovarian PRP, but it doesn't work for me. I don't know why. Not it doesn't work. Anything you can add here?
Nowadays, we are checking because we know that in some patients it doesn't work. We try, and we can't activate more eggs. Maybe because we don't have, if it's menopause, the problem, or maybe because the way that the PRP is working inside the uterus is not working with this case. That can happen.
Okay, again, and if we can go back to the previous question from Marie, just to make sure and clarify. Sorry, I did not understand. So no activate eggs. I mean, does it mean that there are no eggs, not even dormant eggs?
When I talk about activate eggs, is like they are going to start growing. Or the follicles, the egg is not growing, it's maturing, but the follicle is growing. So we prepare, if we have a normal ovarian reserve, we are preparing many eggs to ovulate, but finally we only ovulate one of them. So what we can see with the ultrasound, we can't see the eggs directly. Okay, we can see the liquid inside the eggs, but we can see if there are activated eggs, because we think that inside the liquid there are eggs. So what we want with PRP is to activate, to make eggs produce. No, this is not make from the egg, but we are going to tell that to produce this kind of follicle, to increase the quantity of eggs that we can stimulate. Okay, and that we can in our clinic, or maybe naturally our body can stimulate the eggs if we activate the eggs from the beginning. I don't know if that's the point.
Marie, let us know if that explains it. I think that it is clear for me, but of course, if you have anything that you would like to add, go ahead. And I believe now one more question is here, so let's see it. So, are there any possible side effects of PRP of ovaries? I mean, sorry, after PRP of ovaries, possible infections. Is that what you meant by the same side effects as the puncture of embryo collection?
Yes, that's the point. Or maybe
Okay.
bleeding, or maybe an immune reaction. Maybe
Mhm.
we can punction other sides of the body when we introduce the liquid. That's not frequent. Okay, there are
Yeah.
side
Okay.
effects. Yes.
There are some side effects we need to be aware, of course, as well.
Mhm.
Okay. Thanks a lot. One more, possibly one more question. I'm not sure. Someone is typing, so I just want to have a look. We will be finishing. Excuse me, but I think we can still give it a minute and see if we have another one. As you can see, Dr. Rodriguez, there are some things coming up your way. So thanks a lot already, everyone, for your questions, and Dr. Rodriguez for answering all those questions. And
you
as you
for
can
so
see,
many questions. I'm very happy with the question because this is an interesting topic. So
definitely, this is a topic that as I mentioned even before we started, this is a topic that we could discuss and more. And of course, we will be doing some more topics on this particular PRP, ovarian, but also uterine rejuvenation. So just stay tuned, okay? I'm sure you will see that we will have lots and lots of topics on this and webinars, of course. Again, someone is typing. I just want to make sure, but it looks like we will be finishing for tonight. So before we finish, thanks everyone for joining. Thanks for your questions, Dr. Rodriguez. Is there anything else you would like to add before we finish for today?
thank you all, and I think that we can continue talking about this topic because we will have more information in the future, and I will be glad to inform you about that.
Definitely. And if you may just have a look. So can we activate those eggs that are first seen during ultrasound but are not collected during the classical procedure?
If we see some follicles and they are small and they are not growing, maybe it's because another problem. Maybe there are not egg inside the follicle or other things. We have to think another problem. Maybe we can't improve with PRP those eggs. Maybe not.
Okay. All right. I do not understand. So if dormant eggs are visible through the ultrasound analysis, or if with other
No.
tests, or if we have more chances through the new techniques to discover and activate dormant.
We try to activate, but we can't evaluate them before trying PRP.
Yeah.
Yes. Nowadays.
Nowadays, at least, yeah. Definitely. So there, it's not, as I mentioned, it's always, it's not that easy. It's still a little bit more complicated. It's hard to just give you like a proper answer exactly. But of course, thanks a lot. And I believe that was again helpful. Brilliant. Thanks a lot, Mari, for your follow-ups, for your questions. Thanks everyone for your questions. And I believe it was really, really helpful. So Dr. Rodriguez, thank you so much for your presentation, for your time. I know that you have some time to work because you are taking care of patients all the time. And after we finish, Dr. Rodriguez will also take care of her patients. So we will be finishing for tonight, but I'm glad that we were able to talk about this and to answer some of your questions at least as well. And remember, we will be back. Actually, this week we will talk about implantation windows. So if this is something that you find interesting, then of course join us. We will be back on Thursday at 7 p.m. UK time. So I hope you will be able to join us. This time we will be talking about implantation window with Dr. Elena Santiago. So hope you will be able to join us. But thank you everyone for tonight. Dr. Rodriguez, thank you a lot. It was great to have you here as our presenter. And I'm looking forward to some more events with you. It was really good to have you for sure. Thanks a lot, everyone. And enjoy your evening as well.
Bye. Have a nice day.
Bye. See you. Bye.
Bye. See you.